Buongiorno. Thank you, Dr. Muir. Thank you, Dr. Brendelin. And thank you to Claudio for this kind invitation and for always supporting and himself advancing the care of children with acute kidney injury. These are my disclosures, and none of them are relevant to the content of my talk. So I know we've all discussed the different criteria for acute kidney injury in adults, and these were the first criteria, the Rifle criteria, looking at risk with a creatinine-based or urine output-based criteria, injury, a doubling of creatinine, a more prolonged oliguria, failure, tripling of creatinine, more prolonged oliguria, or a period of anuria. And these criteria and their progeny have been studied in over 1 million adults. And while we can't read everything on this slide, what we've learned over the last 10, now really 15 years, is that the mortality in adults increases with increases of Rifle strata in every single study. Doesn't matter if a patient has a community-acquired pneumonia, status post cardiac surgery, heart transplant, liver transplant, acute kidney injury is independently associated with mortality and morbidity in adults. About a decade ago, we created a pediatric modified Rifle criteria, and this has been assessed in about 100,000 children to date. And what was noted in a systematic review a few years ago is that the AKI rates and distributions varied with the population studied. Unlike adults, which is interesting, the IRF, so pediatric Rifle injury or failure, or akin stage 2 or 3, or KDIGO stage 2 or 3 is where the associations with mortality tend to be. So in pediatrics, we have a little bit of a different epidemiology, and we really should use the first stages to direct management change. So risk is truly risk. It may not truly be acute kidney injury in terms of being associated with morbidity and mortality, but we should pay attention. The akin criteria then modified Rifle and put the 0.3 milligram per deciliter or 44 micromole per liter increase in to get us to stage 1. And then the KDIGO definition that we are all operating with now harmonized Rifle, pediatric Rifle, and akin. And so you've all seen this over the last 48 hours, but again, acute kidney injury is assessed or defined as a 0.3 rise, 0.3 milligram per deciliter rise within 48 hours, a 50% rise over baseline within 7 days, or oliguria. And what's really critical is that 95% of the epidemiology that's been described has only focused on the creatinine criteria, because it's easy to extract that from the creatinine data from electronic health records, whereas it's not so easy to extract that from urine output from electronic health records. So we have started to have some bigger studies, larger studies of acute kidney injury in children, and this study by Scott Sutherland from Stanford University looked at about 14,000 children, comparing the pediatric Rifle criteria, the acute kidney injury network criteria, and the KDIGO criteria. And he looked at both ICU and non-ICU populations. And what you see here is that each of the criteria do end up creating a little bit of a different epidemiology, and this was only based on creatinine. But patients with stage 3 do worse than patients with stage 2. Patients with stage 2 do slightly worse than patients with stage 1, and altogether, with respect to mortality and with respect to morbidity in the ICU on the left-hand panel, mortality, AKI stage, and severity is independently associated with mortality. This was a retrospective analysis from a database in Stanford. Fortunately, we now have validated the KDIGO criteria. So these data were published from the AWARE study, published earlier this year in the New England Journal of Medicine. AWARE stands for the Assessment of Worldwide Acute Kidney Injury, Renal Angina, and Epidemiology. AWARE took patients from 32 centers, 9 countries, and 4 continents. This was a prospective observational study of children admitted to ICU or cardiac ICU over a 3-month period. The only patients who were excluded were infants who underwent congenital heart surgery, because that population has been studied extensively. The aims for AWARE were to describe pediatric AKI epidemiology and potential associated outcomes in children admitted to ICUs around the world, to determine if the renal angina index in the first 12 hours of ICU admission can predict severe AKI, KDIGO stage 2 or 3 AKI on ICU day number 3, and to determine if addition of urinary biomarkers to the renal angina index can improve AKI prediction. I'm only going to discuss the first bullet point today about epidemiology and associated outcomes, because that's what was described in the New England Journal article. So the exposure, again, is KDIGO stage 2 or 3 AKI in the first 7 days of ICU admission. And we only followed patients who were admitted past day 2 of ICU, patients who were admitted for less than 48 hours. We collected their data, but we did not include them in the outcome analysis. The primary outcome was 28-day all-cause mortality. Secondary outcomes were PICU length of stay and need for mechanical ventilation. Here's the consort diagram. So over at each center during 2014 picked 3 consecutive months in the calendar year to follow their patients. So during that time, 6,800 children were screened. A number were excluded for most of the exclusion criteria. Either they were fresh kidney transplants, so we did not look at those patients, or they did not stay in the ICU for more than 2 days. This left us with 5,200 patients. 250 patients had missing outcome data. So at the end, we had close to 5,000 children that had 28-day outcome data. There were 4 deaths that did not have complete data, so they were excluded from the final analysis. And overall, the epidemiology shows using the KDIGO creatinine and urine output criteria. So a patient just needed to fulfill one of the KDIGO criteria, and the stage of that was higher was the one that was used. So if the urine output criteria resulted in stage 3 and the creatinine criteria resulted in stage 1, that patient was determined to have stage 3 acute kidney injury. 27%, so 1 in 4 patients admitted to an ICU around the world developed acute kidney injury. And if we look at the primary exposure of severe AKI, again, KDIGO stage 2 or 3 AKI, 11.6% of the patients, 1 in 9 patients admitted to these ICUs had a severe acute kidney injury. The mortality rate for AWARE was 3.5%. So if most of you are adult practitioners, you might think that that's pretty low, and it is compared to an adult ICU, but this is the mortality rate reported in pediatric ICUs around the world. So we can say that the AWARE cohort is representative of a worldwide pediatric cohort in terms of mortality. When we look at the 5,200 patients, we find that the primary diagnoses are very similar to what you see in adults: shock, cardiovascular disease, respiratory disease, surgical and trauma. We do have more CNS, central nervous system disease, than you tend to see in an adult population, and 4% of the patients had either a solid organ, non-kidney solid organ transplant or a stem cell transplant. We looked at 16 variables, not all of which are listed here, that had a p-value of 0.15 or less for an association between that variable and 28-day mortality, and in a multivariable regression analysis that included all of those variables, severe AKI was independently associated with mortality. The patients, non-survivors, 36.4% of them had severe AKI. Survivors, only 10% of them had severe AKI. This led to an odds ratio of 1.77, so independent of 16 other variables, severe AKI conferred a 77% increase in risk. And the reason that this is important and why AKI epidemiology is important in children is that children do not have the same comorbidities that adults have that can confound an association with mortality. They do not have diabetes, they do not have cirrhosis, they tend to not have solid organ malignancies like lung cancer or liver cancer, and they don't have chronic kidney disease. So they're a purer example of the potential association between acute kidney injury and mortality. And therefore, we were able to say that maybe AKI is actually mediating part of the risk for mortality in children, and I think and young adults, and I think that's very informative for the AKI field. The Kaplan-Meier survival curve, again, shows a staged association between AKI severity and outcomes. And what is also interesting about kids that has been described before and is not necessarily true of adults is that in the first 7 days, we see the prevalence of AKI increasing up to about day 4. From day 4 to day 7, severe AKI rates did not change very much. And this is important epidemiologically because we can now target interventions earlier if we have a good risk stratification system and if we're able to put biomarkers in to help us determine who's truly at risk for AKI. This has been shown in pediatric ICU studies repeatedly. Kids develop their maximum number of organ failures early, usually within the first 72 hours, unlike adults who can develop significant addition of organ failures over a longer period of time. Besides the mortality signal we saw, the most important aspect of AWARE is that we had very good urine output assessment. And what you see here in yellow is AKI by urine output criteria, and on the y-axis is the mortality. And what you can see here is that patients with stage 3 AKI by urine output criteria had a 33% mortality, significantly higher than those who had stage 3 AKI by creatinine criteria. And this is the first pediatric study to look at the urine output criteria in a large data set. More importantly, we had about 3,300 patients who had adequate data by both serum creatinine and by urine output. And if we looked at the patients who had severe AKI by urine output criteria, when we looked at those patients' creatinine changes, we would have missed 2/3 of the patients with severe AKI if we had only looked at creatinine in that group. That informs us that when we have a patient who's at risk of AKI, we want to keep the Foley catheter in to accurately measure urine output because the association between urine output AKI and oliguria and mortality is so strong. I now want to focus on the neonatal AKI, and there's been a significant increased attention on neonatal AKI over the past few years. And the problem with neonatal AKI is how do we define it? Because there are a number of glomerular generations that continue in the neonate, and in preterm neonates, they may not have completely mature nephron number. So what is normal preterm renal physiology? In fact, we could think that premature infants all have abnormal physiology. And because they can't take in adequate fluid and nutrition, what does what the clinician do help determine what's normal? And in fact, if you look at the GFR by inulin clearance for age and term infants, you can see that infants do not generally have their fully mature GFR until 4 to 6, or even in some cases up to 12 months. In preterm infants, it's even more confounded and difficult to assess. So how would we assess true chronic kidney disease? How would we assess acute kidney injury in preterm neonates? And as we all know, serum creatinine is a surrogate of function and not injury, and that we need 25 to 50% functional loss prior to creatinine changes to occur. It's difficult to adjudicate acute kidney injury while the nephrons are maturing. Serum creatinine is affected by medications and by bilirubin, and many of these patients have hyperbilirubinemia, and by muscle mass, and preterm infants have almost no muscle mass. So serum creatinine rises in prerenal azotemia. Is that AKI in these patients? Because remember, infants will lose up to 10% of their body weight in water in the first week of life. Also, blood loss from daily measurements is a big deal in babies, so getting daily creatinines is not the standard of care in infants who are in a NICU. And if we look at different gestational ages and what happens to serum creatinine, this we would consider to be potentially the AKI threshold that has been discussed in the past, basically a creatinine of 1.5 milligrams per deciliter. But if we have a patient whose creatinine goes up by 50% here, but their creatinine level is coming down by normal physiology and getting rid of maternal creatinine, is this AKI? Or is this lack of improvement AKI? It's really difficult to understand what acute kidney injury is and how to define it in preterm neonates. So former fellow of mine, David Ashkenazi, has developed the Neonatal Kidney Collaborative, and they created a retrospective observational study called AWAKEN, Assessment of Worldwide Acute Kidney Injury Epidemiology in Neonates. These data are being submitted for publication, and I'm grateful to David for sharing them to me. This neonatal AKI staging system is empiric and has not been validated, although I'll show you that AWAKEN seems to have validated it. And you can see that there are different modifications for urine output and for creatinine compared to what is seen in KDIGO. And when they applied this criteria in AWAKEN in about 2,200 preterm neonates, what they found was, again, a significant association between AKI and mortality and length of stay for preterm neonates. Here you have the rates of AKI, yes or no, and interestingly, just like in AWARE, 28% of all neonates admitted to these NICUs in North America and Australia developed AKI, exactly what we saw in AWARE. And you can see that patients who did not have AKI had a very low mortality rate. Only 2% of patients without AKI died, whereas nearly 9% of patients with AKI by these Ashkenazi criteria died. In a multivariable regression analysis, the odds ratio for death for patients who developed AKI was 2.9, which was significant. And for length of stay, the odds ratio was 8.6. So while this will need to be these criteria will need to be validated in prospective studies, we now at least have a neonatal AKI definition we can test, and we should start to look for AKI and how to prevent it in critically ill neonates. After cardiac surgery is a nice translational model of acute kidney injury. The timing of AKI is known. The epidemiology of AKI is known with a 40% AKI rate. Younger aged and prolonged bypass times are risk factors. It's ideal for novel biomarker studies and ideal for long-term follow-up. But again, if we look at a large retrospective study from Texas Children's Hospital, AKI stage 2 conferred a 5.1 odds ratio for ICU death in these infants, higher than the association with single ventricle physiology. Now, I wouldn't want to wish a single ventricle physiology on any infant, but AKI is at least, if not more, of a risk factor for mortality. In addition, patients who have acute kidney injury after cardiac surgery are at risk for long-term sequelae. This study out of Canada demonstrated that at 2 years, children who had acute kidney injury were more growth stunted than those who didn't. We just recently published a long-term follow-up of acute kidney injury after cardiac surgery in children. This comes from the Danish cohort study. It's a population registry that doesn't just look at administrative coding, but also looks at creatinine. These survivors from heart disease were born between 1990 and 2010 and had cardiac surgery between 2005 and 2010. AKI was defined by KDIGO within the first 5 days of cardiac surgery. We excluded a number of patients who had CKD, and the outcome was the cumulative incidence of CKD stage 2 to 5 using outpatient creatinines, and they had to have 2 creatinines that qualified for CKD at least 3 months apart so that we weren't seeing another episode of AKI. We computed the hazard ratios, and we adjusted this for sex, age at the first cardiac surgery, year of the cardiac surgery, and congenital heart disease severity. And what we found is that at 5 years, patients who had cardiac surgery-associated AKI, 12.2% of them, 1 in 8, had chronic kidney disease. There's still a background prevalence of chronic kidney disease in patients who didn't have AKI after cardiac surgery. But again, the odds ratio here is about 4 when we compare cardiac surgery AKI patients with those who didn't have AKI. And you can see the Kaplan-Meier curve here demonstrating again that patients who had 1 episode of AKI 5 years earlier had increased risk for CKD, so we should follow these patients. Again, they do not have diabetes, cirrhosis, or other risk factors that adult patients have. So in summary, this brief overview, AKI is very common in critically ill children and infants from ICUs around the world. It's associated with increased morbidity and mortality in children and infants, and long-term follow-up is warranted for AKI survivors to assess for CKD development because hopefully they have decades and decades of life ahead of them. I want to thank Dr. Ronco again, but also thank my colleagues in the Center for Acute Care Nephrology at Cincinnati Children's Hospital. They do all the work, and I get to come to Vicenza and drink wine with Professor Ronco. So my life is pretty charmed.